This program is sponsored by the Spine and Orthopedic Institute at St. Vincent Charity Medical Center. Quality you can believe in. And co-sponsored by the Joint Implant Surgery and Research Foundation, dedicated to the advancement of total hip, knee, and shoulder surgery since 1971.
One broad question before we get into specifics on design features. It seems like there is a current trend that has been building over the last few years on medical decision making that is being taken away from the orthopedic surgeon and coming down to more decisions by hospital administrators and purchasing and the financial people. And it appears to me that we're all concerned with the government, insurance agencies trying to make what you guys do as master surgeons become generic, and what I do as a designer to become generic. And it's very difficult anymore to maybe try to get the features and benefits of technology. I'd like for each of you to comment on how you're faced at your local institution with maintaining your integrity on product selection and technology selection.
At our institution, we're lucky in that the surgeons make the decisions about what type of implants are going to be used in the hospital. We place, for instance, I use 5 or 6 different types of total knee systems. I use 4 or 5 different types of hip systems, and I try to patient match the implant. So for each individual patient, I'm thinking about which implant would solve this patient's problem best. And I'm in an institution where I can make that choice. Now, I have the responsibility to push back on the vendors and say, listen, I'm not going to pay an exceptional premium for this particular implant. I don't want to bankrupt my institution. So I'm lucky enough to have the choice, but I also have the responsibility of making sure that what I'm providing is reasonable and cost effective for the patient as well, and is appropriate for the patient. I don't need to be putting in an exotic bearing material in an 85-year-old patient. That doesn't make sense. But if I have a 42-year-old guy who played football and has premature osteoarthritis of his hip, and he works as a fireman or a cement worker, or I need to get him a high-performance device. I'm going to try to, I don't really care too much about the expense of it, because over the length of his life, it's got to perform a long time, and so a little bit more invested up front, I think, is going to pay high dividends for that individual patient. So that's our approach. We've been lucky.
Dr. Mackel, you've been involved at the board level with the American Association of Hip and Knee Surgeons, and I'm sure this issue has been a topic of concern and debate. What do you see at the national level on policy?
Well, I think that it is becoming more and more a topic of conversation. Institutions are either capitating price and allowing all the vendors to kind of bring in different implants at a capitated price for the different type of bearings, be it a all cemented implant system, the traditional hybrid system, a cementless system, and then kind of all the variations of the cementless systems. Is it standard titanium or cobalt chrome, or is it a trabecular metal or gription type surface, or more highly grit blasted surface, say, for the acetabular component? So we see more and more creations of buckets of implants, and I think it goes back to what Lou just described as demand matching the patient with the implant and trying to capitate that price of those implants. But you also see institutions where there's 1 or 2 vendors are are being limited to a hospital system, and the surgeon has to try to pick various implants from one or two vendors to supply. And I think that all the vendors are so much different in terms of what they have. I don't think there's a good answer, and I think we as surgeons have a responsibility to, select the best implants for our patients based on our training, our experience, and what's going to match that patient's goals best. So I think from a national level, I don't see a particular direction we're going other than the prices are being more and more capitated in hospital systems. And I think our responsibility as surgeons is to try to continue to explore and really not allow these changes to affect our unique ability to try to pick the best long-term implants. And maybe what will help this down the line is the joint registries as they come about. So I think as the joint registries evolve, that may help better solve which are the best implants for patients.
Dr. Rubash, a little different question for you. With the advent of some of the newer technologies and the internet, how are you being faced from patients coming in and demanding, say, hip resurfacing or metal on metal? Do you see that, and are you concerned about that? Is it taking more of your professional time to explain that, or what, if anything, has been your situation with regard to the internet and information?
Well, just one comment, and then I'll go to that question. The problem that we face is that our patients, our physicians think that implants are uniquely specific for a patient for a given outcome. Our payers think they're commodities, that they are generic. So a hip stem is a hip stem, a socket's a socket. And they are the ones that control the finances. So they're ultimately going to be the ones controlling the decision making. So I think that the die has been cast there from the national standpoint. Now to bring that back, and I think the need for a national joint registry, as we've seen with so many other countries that have them, is that you can change surgeons' behavior by having good data and showing, for instance, with a joint registry early failure, or showing with a joint registry highly successful implants at 5, 10, and 15 years. So I think that we desperately need, as suggested, a national registry to be able to differentiate between these implants. So the question of patient demand, well, you can go on the internet and you can find any medical opinion that you want for any given condition, and the problem is that 95% or more of it is incorrect. So I think that we have, in many cases, patients are very confused about what they're finding on the internet. They hear of outrageous claims. They see people doing outrageous things with artificial joints, and so they're confused. And I think it's critically important that we provide good information. So when I see a patient and they start to talk to me about internet, things that they found out about on the internet, I refer them to our Academy website and I say, listen, that's a great source of information. It's validated by us, and I want you to go there if you have any specific questions. You can write them down, and when you come to see me the next time, I'll be glad to go through them with you. Direct-to-consumer marketing, which I think is another real source of both good information as well as confusion for our patients, is putting yet another layer on the patient's quandary, and that they see outrageous claims perhaps on the internet. They see direct-to-consumer marketing saying that this particular implant is better than that particular implant, and it may have a 20-year survivorship. Most patients don't understand survivorship and survivorship analysis in its technical terms.